giornata per tutti.
So just to answer the questions I received a few minutes ago, or 1 hour ago, this is the way how I do a continuous longitudinal approach. The catheter is here. You see exactly the length of the needle and the catheter that has been pushed 1 to 3 more centimeters away. So this is a quite advanced technique, but a very efficient I used every day for my knee surgeries. So I've been asked to take the place of the lecture of Rafa, and I have a lecture that fits more or less with what was supposed to do. And before to start, I would like to know how many of you do paravertebral block? Very few. And how many of you do PEC blocks for surgeries? Very few. So I really hope that you will change completely your way of doing. Unfortunately, there are several slides on the paravertebral block, but the real topic is really the PEC blockers. It is a really much more easy, really very easy technique that all our patients will benefit. We will first look to some anatomical point, some technical aspect of the PEC 1, 2, 3. I will explain you why paravertebral block and PEC blocks are effective for acute pain, but in my mind, this is not the most important point of view. This is the most important, is that PEC blocks helps you to avoid, to minimize the incidence and the severity of chronic pain. And then we will move to some mechanism of actions. I will skip some slides because it is already very late. So the paravertebral block is obviously a central block, while the PEC 1, 2, and SERRATUS block are obviously distal and peripheral block. Should you compare these two techniques, paravertebral block has a lot of advantage, as it was already described more than 1 century ago. It benefits from evidence-based Cochrane review analysis and many recent papers and very strong papers have been published these last years. On the other hand, the PEC block has only been described a few years ago by Rafa, and very few papers, and this is still surprising for me, have yet been published. But I'm personally convinced that it will widespread very rapidly. First of all, it is mandatory to understand how complex is the innervation of the breast, as it benefits from branches coming from the cervical plexus, from the brachial, and of course, of all the thoracic nerves. By the way, you see that the second intercostal nerves, most of the fibers are going this way to the arm. It means that in this area, you have a gap, and this gap will be fulfilled by some branches of the supraclavicular nerve. So we see that this contribution of the cervical plexus here at this level from the supraclavicular nerve is not always present in different anatomical papers. So it is changing from one patient to the other one, but it is still present in at least 60 to 70% of the papers. Secondly, these blocks or this area receive some fibers from the brachial plexus that are the pectoral, the long thoracic, and thoracodorsal nerves. The pectoral nerves are located in this area exactly between the PEC major and PEC minor. And these are medial and lateral pectoral nerves. On the other hand, in this area, and this is the pectoral nerves are extremely important for breast augmentation, while the long thoracic and thoracodorsal nerve are extremely important for the dorsal flap. Should you inject the PEC1, this is what you obtain, but it is probably more clear and more easy should you look to this opacification. You see perfectly that with 10 ml, only 10 ml, the dye fulfill all the space between the PEC major and PEC minor where are located the two nerves. And with only 10 mics, you go really from the clavicula down to the first rib. Everything is covered with a quite small volume. But very interestingly, you see that the dye doesn't go away in this direction. This is because of the ligamentum suspensorium maxillae that is also called the Jurdy ligaments. And while once Rafa Blanco noticed this, because he does some methylene blue injection, he thinks about doing the PEX2. Importantly, should you look to the thoracic nerve, it is extremely important to note that when you do a block in this area, you only block the lateral intercostal branches and not the anterior branches. This practically means that you put a sleeve when you do a PEC2 only the lateral side of your breast. While, on the other hand, when you do a paravertebral block, you block both sides, medial and lateral side of the breast. And there is nearly no overlap. Fortunately, most of the tumors are located in this area. According to this same study, we see that we must absolutely block the 4th intercostal level, but also the 3 and 5th. And should you want to have a complete block, you must go from 2 to the 6th intercostal nerve. And this is very important. We will see immediately why. So the PEC2 has seen recently some evolutions. The first block described by Rafa was described at the level of the 4th rib. This is not always easy, especially in patients who are slightly obese or who have large breast. Then, and it is nearly the same, it appears to be slightly more easy and mainly more safe to inject your dye contrast just here behind the PEC major, the PEC minor. It means that you are doing, in fact, an infiltration in this area, with as a result that you have methylene blue here, dye, in all this area. But if this is the intercostal brachial nerve, this will be the 3rd intercostal nerve. This will be the 4th intercostal nerve. And you see that this area is not perfectly stained by the methylene blue. This is simply due to the fact that while we do this block, we do a single bolus injection, and in most of the case, we have a concentric spread in all the directions. And that's not always what we are willing. That's why we suggest to do a forward infiltration that can be done from cephalate to caudal or from caudal to cephalate. So, while doing that, you have the 1st intercostal, 2nd, 3rd, 4th, 5th, 6th. This is exactly what we are looking for. So, first, Rafa described this injection, then he moved there, and actually, some of us are promoting a forward infiltration. The PEX2 is in fact a subcutaneous infiltration, should you look correctly. And this is why this block is so easy and so safe, and I will show you why. Now, some people are doing SERRATUS block. This is what we are doing partly with this SERRATUS injection. This SERRATUS block can be performed on one side or on the other side of the muscle. And you see that when you inject this area, you have all the lateral intercostal branches here, there, 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 that are leaving the intercostal space and that are going to cross this area and that are going to be stained and affected by the local anesthetic. And you see, this is exactly what we achieve. You have here the serratus muscle that is perfectly lifted here, and you have your dye solution that is located there. You have the serratus that is lifted by the local anesthetic solution, and you see you have the first, second, third, fourth, fifth, sixth intercostal space. You can do major surgery. So, just to come back, the paviter block is a central nerve block. It means that you have a metameric distribution. You are covering all the breast, as well the terminal intercostal branches, as well the lateral one. While the PECs, with the PECs, you will have the pectoral nerve, you will have the long thoracic nerve here, and the intercostal the lateral intercostal branches there. And should you do a small local anesthetic in this area here, you will also have the subclavian nerve. So the paravertebral block and PECs blocks have slightly different territories, does different indication, and may even be complementary. And just because I've not this slide, these last years, some authors, and I do the same when I have a complete mastectomy, we do a medial infiltration along the sternum in order to put asleep all the terminal branches. Both these blocks are efficient. As well, the paravertebral block and the PEC blocks improve immediate postoperative anesthesia. And I go slightly quicker here. This has been shown by Abdallah and Vincent Chan in Toronto once more, that have shown that the paravertebral block here are able to reduce by 2/3 the amount of opioids, but most importantly, they are not just looking to the opioid or the VAS score that are figured here. They are looking to a cumulative quality recovery score, and we will come immediately on that. A quite similar study was performed on mastectomy by Brian Unfeld, and this time they are looking on pain inventory score. Once more, they are not only looking to the pain score, but they are looking to the interference of pain on the daily life, and that's what is most important. They are looking to the general activity, mood, walking, work, relation, sleep of the patient, sleep, enjoyment of life. And they showed that the patients having received ropivacaine have, of course, a much better analgesic score, but that the fact that this quality of analgesia has major influence here on the general activity seems to be extremely important on the chronicization of pain. And this is what has been shown in several papers published already 10 years ago, and saying that severe acute pain is a risk factor for several pain syndromes, including chronic pain following breast cancer surgery. And it has been suggested that relief of acute pain may therefore reduce the risk of chronic pain. And that's what I'm going to show you. The chronicization of pain after breast surgery is in fact a major problem. In this review paper of Perkins and Kellett, you see that they were looking to the pain located at the level of the breast, of the level of, in case of phantom pain, and pain in case of when pain is located at the level of the arm or shoulder. And when you see all these scores, you see that in most of the cases, symptoms are present in more than 40% of the cases. And this is something that most of us are not really very aware, because the patient leaves us these patients are going to radiotherapy, to chemotherapy. They are losing their hairs, they have other problems, but the pain is the primary factor that will influence all the rest of these problems. So this is extremely important and has been confirmed recently in a Cochrane analysis by Andrea, where they say that epidural anesthesia, of course, and paravertebral block, respectively, may prevent post-chronicization of pain after thoracotomy and breast cancer surgery in 1 out of every 4 or 5 patients. So this is not perfect, but at least it will help about 20 to 25% of your patients. This has been shown by Manoj Karmakar. He used this time a SF36 scale that is looking as well to the physical as well to the mental health of the patients, and showed that patients having had a paravertebral block did much better than those who have nothing at all. And this has been confirmed always by Brian Ilfeld 1 year or 6 months after the surgery, using still the brief inventory pain, and you see that patients having received a paravertebral block did much better than those having received a PEC block. So paravertebral block, it has been shown scientifically, is extremely effective, and there is no reason, although it is not yet published, there is no reason that the PECs will not achieve the same results. So the paravertebral block is a target central block, while the PEC blocks are plain field blocks. And that's the reason why the PEC blocks are so easy. So the paravertebral block, different techniques, and we have described some of these techniques have been described. Different techniques are possible. You see that it is always possible to insert a catheter once you have the technique, learned it is, and once you are confident, it is extremely easy to put these catheters, although it is not easy, reproducible. So the tip of the catheter can be consistently be positioned extremely precisely facing the foramen, and each time, as I will show you, it is possible to have, with only 10 ml, a 1, 2, 3, 4 level, a sympathetic block and an intercostal block, knowing that all the foramens are located here. So it is extremely potent. The catheter course, this is extremely predictable, and subsequent spread is perfectly consistent. One more case, not just to show you all the slides I have, but just to show you that you have always the same results. Still one foramen, one sympathetic chain that must be there, 1, 2, 3, 4 levels, and intercostal spread. Extremely potent. Even with minimal local anesthetic amount, you have, it is 1 ml here, 10 ml there, you can have an epidural spread and always local anesthetic facing the sympathetic chain, facing the paravertebral area and the intercostal area. So it's possible to have excellent results in the postoperative period with low volume of high concentration, and this will give you an anesthetic block. On the other hand, as I show you, the PEC2 is a field block, is a plain block. You see that the spread is located here, just behind the pectoralis minor, and that with 30 ml, you cover several levels, exactly what you want. This is a slide of Rafa. He gave me a few years ago already, and you have exactly the same spread here. So the paravertebral block is an advanced technique. You must absolutely go straight from the foramen, from the vessel, from the pleura here. It's a deep block with a steep angle of the needle. On the other hand, as proposed by Rafa, The PEC blocks are superficial block and much more easy, as I show you. So the parietal block is, in my mind, still a very great block, and as such must be respected. The PECs are possibly less potent, in my mind at least, but they have their own indication. And because they are easier, they must absolutely be performed to all the patients undergoing breast surgery. It's, in my mind, extremely important for this patient. Thank you.